Atrial reflex. What's the atrial reflex? This is a reflex that's coming from the atrium. The atrium have a reflex. That's also called Bainbridge reflex. This is an important name to remember. Bainbridge reflex. And this is basically, the atrium is the chamber that's receiving the venous return, which is the blood returning from the veins back to the heart. It goes to the atria. So the right atrium is getting the blood from superior inferior vena cava, deoxygenated blood. It goes to the atrium, and the atrium is going to dilate. So depending on the amount of blood that's coming, it's going to dilate more. And basically the reflex is the more venous return you get, which is more blood pouring into the atrium, the more increased heart rate. Why? Because you're getting more blood, so you need to speed up in order to push this blood away from the atrium, obviously to the ventricles. So what's atrial reflex or Bainbridge reflex? It's increased heart rate in response to increased venous return. How does that happen? Sympathetic activity increase. Obviously, increased heart rate is coming from sympathetic. Now the hormones. What are the hormones that affect the heart rate? These hormones are going to increase the heart rate. Epinephrine, norepinephrine, and thyroid hormone. Remember, epinephrine and norepinephrine, both of those are the sympathetic hormones. So obviously those are going to increase heart rate. Thyroid hormone, I talked about this before, and this is in the endocrine system, that the thyroid hormone acts like a sympathetic hormone, act like a sympathetic situation. So thyroid hormone, we discussed that in the endocrine system, but generally speaking, if related to the heart, we're talking about the heart, it just does the same effect as the sympathetic nervous system. All of these three, epinephrine, norepinephrine, and thyroid hormone, all of those are going to stimulate the SA node, which is the pacemaker, and this will result in increased heart rate. Obviously, if you're in a sympathetic situation, you're fight or fright or flight, you obviously need more blood, so the heart rate should increase. This is in those two. For thyroid, obviously, when you release more thyroid hormone, you're doing more metabolism. So when you do more metabolism, you need more blood to come, so you increase heart rate. And this is the rationale about those. So this is for the heart rate. Remember that the two factors that affect the cardiac output are heart rate and stroke volume. Heart rate, obviously, the rate of contraction of the heart per minute, like 60 per minute, 70 per minute, and so on. And the stroke volume is end diastolic volume minus end systolic volume, which means when the ventricles receive blood, receive more blood, they are dilating. Obviously, this is diastole, dilating, more blood, more blood, more blood. And then it's going to contract to push most of the blood out. So end diastolic volume is the volume of the ventricles at the end of diastole, which is relaxation, obviously. And end systolic volume is at the end of systole, which is contraction. So simply, if we just put some numbers here, just as an example only, if you have, if the heart is relaxing, receiving more blood, let's say at the end, the heart received 100 milliliters. At the end of the relaxation, it's receiving until the end. How much do you have? 100 milliliters, just as an example. This is called the end diastolic volume. And then the heart, because it's full now, the ventricles, the heart is going to contract. The ventricles are going to contract. So you're contracting and you're pushing a good part of this 100 milliliters out. And so you're contracting, pushing out. So you ended up pushing out 60 milliliters. And you end up having remaining 40 milliliters. What are these numbers? The 100 milliliter is the end diastolic volume. The 40 milliliters remaining in the ventricle after it finished contraction contraction is systole, is called the end systolic volume. And the difference between those two, which is end diastolic minus end systolic, which is the part that's already pumped out of the blood, out of the heart, specifically out of the ventricles, this is called the stroke volume. So stroke volume is end diastolic volume minus end systolic volume. If end diastolic volume is 100, if end systolic volume is 40, the stroke volume is 60. And this is about average. So it's about 2/3 are pumped out of the heart each contraction. Of course, this is an average. If you're relaxing, you can get more or less. Like, what if I'm doing some activities or exercise or something? Of course, you can pump more than that. You can do 70%, 80%, and so on. But I'm just saying the average regarding the stroke volume. So if this stroke volume is 60 milliliters in this example, and if we say the heart rate is 100 per second, just to make it easy. If you multiply 100 by 60, this is 6,000, and this is the cardiac output. So heart rate is 100 per minute, stroke volume is 60 per contraction. So if you multiply those two, that will give you the cardiac output, which is 6,000, meaning 6 liters, and so on. You just do a simple multiplication. So we said that the end diastolic volume, I give you in that example, I said 100. What determines, should it be 100, should it be 80, should it be 60, should it be 150? What determines that? The filling time. If you allow more time during the ventricular diastole, which is the ventricular relaxation, so let's say the ventricle is allowed some time, so it's getting like 50, 60, 70, and then you contract, versus if you allowed more time, so 60, 70, 80, 90 is still giving some time, 100, 110. So the more time you give, which is called the filling time, the higher the end diastolic volume. This is one thing. The other factor is the venous return, which is the amount of blood that's coming to the atrium and then to the ventricles in the first place. How much is your body returning? How much blood coming back to the heart from your body, which we call it the venous return. It's the blood returning to the heart from the veins. Venous return. How much of that blood coming to the ventricle? If 100 is coming back, is different than 70 is coming back, and so on. So those are the two factors that affect end diastolic volume. Now there are terms that we need to understand, which is preload and afterload. What's the preload? This is the degree of ventricular stretching during diastole, and you call it preload. Pre means before. Load means you're loading out the blood, pumping out. So preload is what's happening before you contract, which is the degree of ventricular stretching. Like, you're receiving more blood, you're receiving more blood, you're stretching, relaxing, diastole, meaning stretching, relaxing, more blood, more blood. So the more you stretch, the more the preload, the higher the preload is. And obviously this is directly proportional to the end diastolic volume, because more end diastolic volume means more stretching. So this is called the preload, and the rule of the thumb is, as long as you are within the normal limits, the more stretching of the ventricle, the more powerful the muscles are going to contract to push all this blood out. So we talked about end diastolic volume, preload, and stroke volume. If you're talking about at rest versus exercise, at rest, end diastolic volume is obviously low. You don't need all that blood. Less blood is coming back to the ventricles, so less blood is stretching the ventricle, less blood is collected in the ventricles, so the end diastolic volume is going to be low. The muscles are not going to be stretched that much because there is no much blood, and this will end up having, when you contract, you're pushing out less blood. How about exercise? All of this is going to change. If you're exercising, means your muscles are working, getting more blood coming back to the heart, increase end diastolic volume. Because the end diastolic volume increased, that will lead to more stretching of the muscles, And the muscles when the muscles are stretched within normal limits, remember this, within the normal limit, it's not unlimited, but within normal limits, the more muscle stretch, the more powerful the muscles of the heart are going to contract, which is the muscle of the myocardium. The more the stroke volume is going to be produced. Like if I have hundreds at the end of diastole, end of relaxation, I have 100. If I contract it, I can push out 50, but if you contract more, you can push out 60. If you contract more and more, you contract out 70. And this is the stroke volume that's increasing. So that will lead us to the Frank-Starling principle. Frank-Starling principle is the one that I just mentioned. The more end-diastolic volume, the higher the stroke volume. Where is that coming from? It's coming from what I just mentioned, which is the more end-diastolic volume, the higher the end-diastolic volume, means more blood is collecting in the ventricles. The ventricles are relaxing and stretching. When the muscles stretch, the more the muscles stretch, the more powerful it's going to contract. So the stroke volume that's pumped out of the blood because of this strong contraction is going to lead to higher stroke volume. So simply, increased end-diastolic volume leads to more stretching, more powerful contraction, leading to stroke volume. The bottom line, increased end-diastolic lead to increased stroke volume. This is basically like a rubber band. Like if you're having a rubber band and you stretch it a little bit and let it go, it's not going to hurt. But if you stretch it more, it will hurt your hands. Why? Because you're stretching more, and when you let it go, it will go with more power. So the more you stretch, the more power is generated. I just mentioned within within the normal limits. Like if the ventricles are expanding, relaxing, stretching, is that unlimited? Of course it is limited. So if the venous return is 100, for example, that's okay. 70, 80, 100. What if you're exercising more? Okay, it's going to be 110, 120, 100. Is that unlimited? Can it be like 200, 300, 500? What's the limit? There is a limit, and that limit is determined by what is surrounding the heart. There are some connective tissue surrounding the heart that will limit the heart expansion. The ventricular expansion is limited because of these connective tissue in order to make sure that your heart does not burst, does not rupture. It cannot be unlimited. So what are these limits, physical limits? The connective tissue in the heart itself, within the muscle, there are some connective tissue. This is one. Around the heart, there is fibrous skeleton, and there's also a pericardial sac that we talked about before. And all of these three are connective tissue, all of them. So connective tissue have a limited ability to dilate. So until a certain limit, expand, 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 that's it. That's your maximum. Who is doing this? Connective tissue in your muscles of the heart, the fibrous skeleton, and the pericardial sac. In diastolic volume, I mentioned that before. I give you example. If the heart is receiving more blood, more, at the end of relaxation and at the end of diastole, meaning, let's say it's 100, this is called end diastolic volume. I talked about this. But when you contract until the end of the contraction, what's remaining in the heart, or in the ventricles in this case, this is called end diastolic volume. So end diastolic volume is simply volume of blood in the ventricle at the end of diastole. Volume of blood in the ventricles at the end of systole, if I said otherwise. Volume of the blood at the end of the systole in the ventricles. So in the example that I give you, just to make it simple, it's 40. So you have 100 milliliters in the blood at the end of diastole or relaxation. You're contracting. What's remaining in the ventricles? 40. This is called, of course, these are just numbers to make it easy, but it's not real numbers, just something as an example. This is called end diastolic volume, and obviously you should be saying now that the difference between those two, which was the 60 that was pumped out, this is the stroke volume. What determines the end systolic volume? The preload. Preload is the ventricular stretching at the end of diastole. We just talked about it. Remember the Starling law, or the Frank Starling law or principle. The more stretching, the more powerful contraction. So obviously, the preload is going to affect the end systolic volume, because the more stretching, the more powerful. So end systolic volume will end up being less. So contract more, instead of leaving 40, you're leaving 30, and so on. Contractility is the force that's coming from contraction at this preload. How much the muscles are contracting. Are the muscles weak or strong? If it's strong, it will pump out more blood. The other thing is afterload. We talked about the preload, which is the load before contracting at the end of diastole, meaning. What's the afterload? The afterload is the load after, which is the load that's going to face you after you contract. What is that load? This is the tension in the ventricles as it is trying to open the semilunar valve and eject the blood out, which is what's ahead of the blood, what's going to face the blood as it is leaving out. Afterload, leaving out, after. What affect contractility? How can you like increase the contractility, beside the fact that automatically when more blood come, it's going to stretch more, which is the Frank Starling principle or law. This is okay, we talked about this, but if there is another way beside what's happening automatically, like Frank Starling principle is happening automatically, more blood, more stretching, more contraction. Okay. Powerful muscles mean more contraction. Okay. These are basics and these are natural. It's happening automatically, meaning. But can you control the contractility? Can you do something to even increase more? Yes. Autonomic activities and hormones. The autonomic activities, it meaning sympathetic or parasympathetic. If you are doing sympathetic obviously, always remember, sympathetic, you are in a fight or you're running. In both cases, you need more blood that's pumped out, so you have to do two things. Number one, you have to increase the heart rate, and we talked about this. The other one, you need to increase the force of contraction. Remember the cardiac output is heart rate multiplied by stroke volume. How to increase the heart rate? Sympathetic. How to increase the stroke volume? Different factors, but one of them is more muscular contraction. So obviously, if you need more blood, I need to increase the two factors that will help you to get more blood, which are the two factors that affect the cardiac output or increase the cardiac output. What are those two factors? Heart rate and stroke volume, which is coming from contractility. So obviously, sympathetic stimulation coming from norepinephrine specifically, effect on the heart is going to make the heart contract more. The same is happening in the adrenal medulla, epinephrine, norepinephrine. So the muscles are going to contract with more force, and stroke volume is going to increase, and end systolic volume is going to decrease. Like if I have 100, I'm contracting, pushing out 60, you end up having 40. If I contract more because of the sympathetic, I started with 100, I contract more, I'm ejecting out 70 instead of 60. So the ejection fraction, which is the stroke volume, is going to increase, and you end up having 30, which is not 40 anymore, 30. So end systolic volume is going to decrease. Remember, there is an inverse relationship between the stroke volume, or the ejection fraction, we call it. Ejection fraction means what's the fraction that's been ejected. Like in this case, it is 60%, and now it has become 70%. There is a difference between ejection fraction and stroke volume. Both of them are referring to the same thing, but in two different ways. Stroke volume, you're talking about volume. You say 60 milliliters, 70 milliliters. How about the ejection fraction? No, you say 70%, 60%. Instead of 70 milliliters, 60 milliliters. It's kind of related, but the ejection fraction is more of percentage. So what's a fraction? Is it 60%? Is it half? Is it 2/3? That's how much is ejected out. What's the fraction that's being ejected out? So remember, ejection fraction or stroke volume always inversely. There is an inverse relationship with the end systolic volume. How about the parasympathetic? The parasympathetic obviously is going to do the opposite. It's going to decrease the force of contraction. And who is doing this? Acetylcholine. Do I need to remember? Of course you do. Sympathetic is norepinephrine and epinephrine. How about the parasympathetic? Acetylcholine. You should remember those two names. Very important. And that's done through vagus nerve. You need to remember this. So parasympathetic activities, it decreases the cardiac contraction. How or what bring the parasympathetic activities to the heart? Vagus nerve. And what's the transmitter? The transmitter is acetylcholine. And you have to remember this. There are other hormones that affect the contraction. I talked about the thyroid hormone before. Obviously, it acts like, you need to put this in your mind. Always remember, thyroid act like sympathetic. Thyroid act like sympathetic. Basically because you need more energy, so you accelerate everything just like sympathetic. What are the other hormones? You should remember that in this part right here, this is related to other parts in the muscles. I think it was AP1 or Bio233. So anyway, calcium channel. What's the calcium channel? Remember, in order for the muscles to contract, you need calcium. Remember that calcium released from the sarcoplasmic reticulum. This is 233, AP1. Calcium is released from the sarcoplasmic reticulum and it go attach to tropomyosin and troponin, removing tropomyosin away from the active sites of the actin, and the muscle contraction happen. So obviously if you have a lot of calcium, you're going to contract more. If you have less calcium, the contraction will be weak. So they used this idea or this information in order to help making some medications or pharmaceutical drugs. How? They said, okay, so if you have more calcium, you're going to contract more. Yes. What if you have hypertension? Do you need to contract more? Of course not. That will make it even worse. So how about we give something called calcium channel blockers? This is a medication that's going to block the calcium channels, so less calcium available, less contraction. Isn't that a good treatment for hypertension? The other thing is beta blockers. What are the beta blockers? These are the beta receptors. Beta receptors are receptors in the heart. These are, I don't know if you remember that or not. I'm refreshing your information with 233 or AP1. There are different sympathetic receptors. There is alpha and there are beta and others, but alpha and beta are the most important. Beta, specifically beta 1, these are receptors in the heart. These are sympathetic receptors in the heart. Sympathetic receptors in the heart. So when you stimulate these receptors, the heart is going to accelerate. What if I have hypertension? Do I need to increase heart rate? Of course not. You need to do the opposite to treat it. So how about I give you beta receptors blockers? You block the beta receptors. Why? To decrease the sympathetic activity so that your blood pressure goes down. How about if I have hypotension, meaning my blood pressure is low? Can I use the opposite, which is beta receptor stimulant? Yes, you can. So the heart rate is going to increase, and this is going to help you if you have bradycardia or if you have low blood pressure. It's going to increase it. So I talked a little bit about the afterload, and this is basically the afterload is what's facing the blood as it is leaving. After the loads, what's going to face, what are going to see after the contraction, which is the resistance that's going to face the blood as it is leaving. or factors that's going to restrict the atrial blood flow. So this is called the afterload, and the afterload, when it increase, means more resistance is going to face you after, as you're leaving, so stroke volume will be less. Coordination of the heart rate and heart contraction and stroke volume and so on. So what's happening here is these factors are going to affect the venous return, which is skeletal muscle activities, blood volume, peripheral circulation. All of these are going to change the venous return, which is how much blood is coming back to the atrium, to the right atrium. Depending on what, when you contract the muscles more, it's going to squeeze the veins and more blood will come back to the heart. If the blood volume is high in general, like you have 5 liters of blood or you have 6 liters of blood, of course if you have 6 liters, more blood will end up coming back to the heart, which is increased venous return. Change in the peripheral circulation. If you contract the peripheral circulation, which is all these arteries and veins and venules and arterioles, if you contract them, there will be less blood around and it will going to leave the circulation and go, actually not leaving out, it's leaving the peripheral circulation and just go back to the heart more, and this is called increased venous return. If that happen, what's going to happen? Venous return increase, it's going to increase the preload, increase end diastolic volume, and when that happen, you will end up having more stroke volume. And of course that will increase, one of the two factors that increase cardiac output. What else is going to happen if you increase the preload because of the increased venous return? And systolic volume itself is going to be affected as well. So it can go down in that case, and with more contractility. So stroke volume will be, if it is higher, that's going to affect the cardiac output and it's going to increase. Filling time, if you allow more, you're getting more preload, which is during relaxation. You have that's going to affect the systolic volume as well. How about autonomic innervation or hormones? Both of those, so hormones is like something like thyroid hormone, autonomic innervation, like we're talking about epinephrine, norepinephrine as sympathetic, or acetylcholine as parasympathetic. Those are going to affect the contractility. In case of sympathetic, more contractility, less end systolic volume, more stroke volume, more cardiac output. Vasodilation versus vasoconstriction. If you vasodilate, more blood, less afterload, so the blood will not face that much resistance. Remember, the resistance is what's going to face you, or what's going to face the blood as it is leaving the heart after the contraction. What's going to face the load after contraction, after load. If the blood vessels are contracting, which is called vasoconstriction, the afterload is going to increase, and this is more resistance facing the blood as it is leaving, and it will lead to less blood leaving, less stroke volume, because end systolic volume increase. If we do the opposite, the afterload will decrease, more blood will leave out. In all these cases, the bottom line is stroke volume increase, which is one of the two factors for cardiac output, or the other way around, if that the opposite scenario happen, stroke volume decrease, cardiac output decrease. How about the atrial reflex, also known as Bainbridge reflex? If that's the case, the heart rate is going to increase. Same can happen with the hormones. So now you have the two factors, heart rate and stroke volume. If you increase those two, cardiac output increase. If you decrease those two, cardiac output is going to decrease. So heart rate, what can increase the heart rate or decrease it? Autonomic, hormones, venous return, and this is what I just showed you in that picture over here. Autonomic, hormones, and the contractility. But autonomic and hormones, this is the main thing, and also the venous return. Remember, the venous return is the one that's going to stimulate the atrial reflex or Bainbridge reflex, that's going to lead to increase autonomic innervation. So you have three factors: venous return, hormones, autonomic innervation. All of this is going to affect the heart rate. What's going to affect the stroke volume? Or how can you control it? I talked about this before. End-diastolic volume, filling time, venous return. End-systolic volume is affected by preload, contractility, and afterload. This is all in this picture right here. Just repeating. Now, what's a cardiac reserve? Cardiac reserve is the reserve of the heart that you can use as needed. Meaning, if I am resting right now, I'm using the heart a little bit or reasonably, normally, and I'm getting the blood that I need. What if I'm doing a little bit of activities? Can I get more blood? Yes. There is the heart have more reserve. So you can use the heart more. What if I need more? You can use more of the reserve. So what's a reserve? It's the activity of the heart that's reserved to be used as needed. There is a maximum for that. So you can exercise more, you can do moderate, mild, moderate, severe exercise. If you go more than that, you reach the maximum of the cardiac reserve, and you cannot go more than that. If you continue, it will lead to heart failure. So what happens if you decrease the blood volume under normal? Blood pressure is going to drop, which is hypotension, obviously. Remember that. What do you mean by decreasing blood volume? Like if you have injury and you are having hemorrhage, you're losing your blood to the extent of it's going under, not a little bit, more than that. So it goes, the blood volume is less than normal. Like let's say if the normal for males is from 5 to 6 liters. So if you have 6 and it goes 5.5, that's still okay. But what if it go 4.5, 4.5 liters? This is less than normal. If that's the case, blood pressure is going to drop. Less blood go to the kidney. The kidney will release renin. Renin is going to activate angiotensinogen to angiotensin, and angiotensin 1 will become angiotensin 2, and this will lead to release of aldosterone and ADH, and it will lead to thirsty. We talked about this before, and I told you guys before several times that you're going to see this renin angiotensin system so many times in a lot of chapters. So here it is again. The cycle goes on. So increase aldosterone, ADH is going to increase, vasoconstriction will occur, thirsty, you'll feel thirsty. All of this is going to compensate and increase the blood pressure back to normal. But if that continue, the kidney will be stressed and it can actually fail. So it will lead to temporary compensation by this process until you regain the blood, whether you make more blood or you receive blood transfusion like in a hospital or something. But this is all something temporary. If it continue, it will lead to cardiac stress. The cardiovascular system is regulated to ensure that you have enough blood to all the tissues. So if more blood is going, you decrease the cardiac activities. If less blood is going, you increase the cardiac activities. In all cases, you're regulating the cardiovascular system to make sure that you just have adequate circulation or adequate blood to all your tissues, not less and not more than what you need. There are cardiovascular centers that control the heart rate and the peripheral blood vessels as well, and we discussed those before, but just as to refresh it, these are the carotids and the aortic sinus and bodies, which is carotid, aortic sinus, carotid sinus, aortic body, carotid body. These are centers that are located near the origin of the carotid artery and near the bifurcation of the carotid. And these factors are going to measure the blood pressure and give a signal to your cardiovascular centers at the medulla and tell them what's happening there, so they can send either sympathetic or parasympathetic stimulation to the heart. Um, when we say regulation of the cardiovascular system, like if you're exercising, for example, are you relaxing? You need this amount of blood. Are you doing mild, moderate activities, severe activities? Depending on this, you're adjusting the cardiovascular system to respond and give you what you need. There are some emergencies that can occur, like severe activity, heavy activity, heavy exercise, or like in case if you're having hemorrhage or something. This is emergency that the cardiovascular system should be adjusted or regulated in order to respond to these emergencies. The last point here is these important concepts. And these important concepts, I collected it from all over the chapter because I thought this is very important to remember. So when you're done with the chapter, remember that you memorize these terms because you're going to see it in your exam. Whether we're talking about the face-to-face or on campus, I'm using those in different types of questions specifically, the matching, or even online you will see these in different types of questions, multiple choice or whatever. So what's the pulse? This is the alternation of expansion and recoil. Like the blood vessels expand when the blood come, and then it recoil after that. So the difference is called the pulse, which is when you put your finger on the radial artery right above your hand, you feel that pulse. Arteriosclerosis and atherosclerosis, those two terms are very related. I don't think we talked about it before, or we didn't cover it much, but because it's important, I'm going to cover it. So both of those end with this half, which is the suffix, which is called sclerosis. Whether this is arteriosclerosis or atherosclerosis, it's a sclerosis anyway. Sclerosis means hardening and thickening of the connective tissue. Hardening and thickening. In this case, it's hardening and thickening of the blood vessels for two different reasons, and this is bring us to the prefix. Is it arteriosclerosis, which is sclerosis of the arteries, or is atherosclerosis? Athero translated as fat or lipids. Is it just sclerosis of the arteries, or sclerosis due to fat? In both cases, there will be sclerosis anyway. So the recoil is going to be lost because the recoil will depend on this connective tissue and elasticity. Elasticity is going to decrease if you have arteriosclerosis. Like in case if you have hypertension or something, if you have hypertension or something, or if you're pushing too much on the wall of the blood vessels, this will lead to the wall is going to be sclerotic, which is this one right here, and this will lead to when remember that sclerosis is hardening, thickening, hardening and thickening, and less and decrease elasticity. Hardening, thickening, decrease elasticity. Sclerosis is translated as those three: hardening, thickening, and less elasticity. So if that happens, you're losing the elasticity, the wall of the blood vessels will be harder, will be less elastic, harder. So that the case, it's going to lead to hypertension because the pressure that's facing the blood in the wall is going to increase. So heart rate, hypertension. It can lead to stroke, which is the blood can stop at any time going to the brain, lead to stroke, or it can lead to the same thing but in the heart. The heart the blood supply, part of the blood supply can be blocked or decrease, going to the heart or going to the brain. If less blood going to the brain, we call it stroke. Actually, stroke is when the blood stop going to certain part of the brain. Or if less blood going to the heart, it will lead to coronary artery disease. If it's completely blocked, it will lead to heart attack. Atherosclerosis, on the other hand, is basically the same thing, but it's due to fat. So your clue here is fat, which is athero. Ischemia and infarction. Ischemia is two parts, isch and emia. Emia means blood. Isch means less. So ischemia is less blood. So if less blood go to the heart, we call it ischemia of the heart. If the muscles of the heart are not going to receive enough blood and enough oxygen in that blood, the wall is going to be weaker, and we call that ischemia. The heart muscles are not going to die because it's not no blood. The blood did not shut off completely. It's isch, means less. So ischemia, less blood with less oxygen go to the muscles that are going to be weaker. On the other hand, if it's not isch anymore, it's shut down. If one of the arteries of the heart that's feeding the heart, like part of the coronary circulation, whatever it is, posterior interventricular, for example, is blocked, or left circumflex is blocked. One of those is blocked anyway. So blocked, I mean blocked means completely blocked, 100%, not less blood like this. No, infarction is death of the tissues due to complete shutdown of the blood supply to certain parts. Generally speaking, I'm talking about infarction of the heart now, but can it be infarction of anything else? Yes. So let's say infarction in general. What's infarction? Infarction is death of the tissues due to complete shutdown of the blood supply to that tissue. So if that's the case, let's say one of the arteries, you have ischemia before, you have atherosclerosis, arteriosclerosis, whatever it is, the lumen is getting smaller. So something came, a thrombus or something, and blocked this one artery completely. The tissue that was receiving the blood from this artery that's now blocked will get infarction. If you're talking about the heart in this case, it will be infarction of the heart, which is death. Infarction is death, not weak. So this is for infarction. Collateral circulation. Collateral means lateral circulation. Circulation is coming from here and there. This is like, if you remember, the heart will be receiving blood supply from the coronary circulation, coronary arteries, and these coronary arteries are interconnected somehow, and we call that collateral circulation. The more collateral circulation that you have, the better the results. So like anterior interventricular artery in the front of the heart, posterior interventricular artery in the back of the heart. Those two are connected by an artery that's called collateral artery, or collateral circulation in this case, which we also call it anastomosis. Next part is systolic pressure and diastolic pressure. Systolic pressure is the pressure during systole, which is the highest pressure during contraction, during systole. Diastolic, on the other hand, is the lowest pressure during diastole, which is during recoil or relaxation. Like if you say my blood pressure is 120/80, the 120 is the highest pressure during systole, we call it systolic. 80 is the lowest pressure during diastole, we call it diastolic pressure. So when you say my blood pressure is 120/80, 120 is the systolic, which is the highest, 80 is the diastolic, which is the lowest. By definition, artery versus vein. Do not confuse artery and vein with oxygenated and deoxygenated, because these are completely different terms. The artery is the blood vessel that's carrying the blood away from the heart, irrespective of anything else. Is it oxygenated or not? I don't know. Most of the time it is oxygenated, but not necessarily. So what's the anatomical definition of the artery? It's the blood vessel that carry the blood away from the heart. Away from the heart. We call it artery. How about the vein? It's the blood vessel that take the blood toward the heart. The valves of the heart, we have 4 valves in the heart, obviously, but some of them have more than one name, so you need to remember these names. The mitral valve is also known as bicuspid valve or left AV valve, which is between the left atrium and left ventricle. You have to remember all these 3 names. Don't pick one of those. All 3 are important. Tricuspid valve have only 2 names. There is no nickname like this. Like this is called bicuspid or left AV valve. A nickname is mitral valve. This one does not have a nickname. This is called tricuspid valve because it have three. Tri means three. Cuspid means cusps or leaflets. So this have three leaflets or three cusps. We call it the tricuspid. This have bi means two. It have two cusps only. The other name for tricuspid valve is right AV valve, but there is no third name. There is no nickname. This is between the right atrium and right ventricle. Tachycardia and bradycardia, this is the heart rate increasing or decreasing the heart rate. So if we say the normal heart rate is somewhere between 60 and 90, remember that it's usually a range. You can't say my heart rate is 70, so I'm okay, and the other person is 80, he's not okay. No, it's a range. As long as you are within that range, you're normal. So the normal range is usually between 60 and 90. Sometimes they extend it to 100, but in all cases, more than 100 is tachycardia. And what's tachycardia means? Tachy means fast. Cardia means heart. Fast, heart. Brady means slow. And this is not the only time that you're going to use these prefixes and suffixes. This is a prefix that means slow. When you do respiration, or if you did a respiratory system, you will see bradypnea. Pnea means respiration. So bradypnea means slow respiration, and you can use it in other terms. So always try to remember these prefixes and suffixes. So brady means slow, tachy means fast. Bradycardia, slow heart rate, less than 50. Tachycardia, fast heart rate, more than 100. You have to remember these numbers. This slide in general is very important to remember. Heart rate is the number of contraction or systole per minute. Usually we refer to the left ventricle. The right ventricle is contracting at the same time with the left ventricle, but we refer more to the left ventricle because this is the one that's more important. This is the one that pumps the blood to the entire body. So we usually refer heart rate to the ventricles in general, but specifically the left. Cardiac output, we talked about this before, it's heart rate multiplied by stroke volume, which is amount of the blood that's pumped out per minute. Per minute. If the heart rate is 100, stroke volume is 60, just as an example, your cardiac output is 6,000, which is 6 liters. Let's say make it closer to normal, it's going to be 5 liters. This is the around, it's a range. So that's it for this chapter, and we will stop here.